Hi, everyone. Welcome. Just going to give it another minute or so as people join. Welcome, everyone. Just going to wait another 30 seconds or so for people to get out of the waiting room. Okay, we'll go ahead and get started, and as people trickle in as we go. But welcome, everyone. We're here with the Selective Mutism Association. My name is Jonathan Kohlmeyer. I'm on the board of directors. I'm here with Dr. Rupal, who's also on the board of directors, and we'll introduce herself in a moment. But before we get started, I just have a few announcements. This webinar is brought to you by the Selective Mutism Association, as well as the Gordon and Marilyn Macklin Foundation from a generous grant by them. The other thing to note is this webinar is being recorded and will be available on our YouTube channel, probably within a week or two after this webinar is finished. And a link to the recording will be sent to every registrant who attended today. We'll have lots of opportunity at the end for Q&A, but we want everyone to ask their questions in the Q&A box, and we'll get to all questions at the end of the presentation. And also just to put on everyone's radar that our annual conference is open for registration, which is in October. If you go on the SMA website, you can find details about registering for our annual conference. So I'm going to kick it off to Dr. Rupal. This is an awesome presentation. Topic of medication comes up quite often when parents, guardians, teachers, psychologists are thinking about treating selective mutism. So this is a very important talk, and it's a very big decision for lots of parents to make. So I'm going to kick it off to you.
Thank you so much, Jonathan, and thank you for being here. The presentation today, A Hard Pill to Swallow, is going to focus on the medication management of children and adolescents with selective mutism. Again, I'm Dr. Rupal Upadhyay, and with us is Jonathan. He's going to be moderating. And as we said, if you could please submit your questions in the Q&A as they come up, but just to respect everybody's time, we'll go through the presentation. There is definitely going to be time at the end that I've allocated for questions, so we will have time for that, but we'll run through the presentation. And thank you again. As Jonathan mentioned, this webinar was made possible thanks to a very generous grant from the Gordon and Marilyn Macklin Foundation. So again, my name is Dr. Rupal Upadhyay. I go by Dr. Rupal in the office. I am a board certified pediatrician. I've been in practice in a private group practice, associates in pediatrics. My clinic is located in the northwest suburbs of Chicago, and I've been with the practice for just a little over 17 years now. My educational background and training is in primary care and general pediatrics, and all of it, as you can see, was local here in the Chicagoland area. And I have listed some information about my practice, the website, and I do also, for those of you who are on social media, have an Instagram channel. It's at Peds Health. It is a public channel that I share with all my patients. You are welcome to follow. I do like to post lots of updates and educational information on anything relevant in the pediatric field. I do post lots of information about topics related to anxiety and, of course, selective mutism as well. So actually, I'm going to go back once. the way that I actually became involved in the Selective Mutism, with the Selective Mutism Association, about 6 years ago, my daughter was diagnosed with selective mutism when she was in kindergarten. And despite the fact that obviously I had experience as a pediatrician, I was still learning and kind of navigating as a parent this new diagnosis for my daughter. Along the way, I met lots of knowledgeable people. I became involved in a lot of different parent support groups and just found lots of incredible resources to really help guide us and my family with my daughter's diagnosis. Since then, I have, really taken a new level of interest in treating my own patients with anxiety and selective mutism. And I feel like it's such a great opportunity for me to offer a perspective that's really unique. And, as we talk today, obviously I'm going to help educate you and teach you a little bit about the treatment, particularly medication treatment that's involved in childhood disorders like anxiety and selective mutism. But I'm also going to put my mommy hat on and be able to give you a perspective from a parent with a child that has selective mutism. So as we go through tonight's discussion, I will definitely weave in our journey with my daughter. And sort of the thought processes that I went through as a parent, as well as some of the educational information that I'll share with you as a pediatrician. So again, my story starts with my daughter. This is Leela. She's there with our dog Cosmo, who, don't be surprised if either one of them do make a quick appearance at some point tonight. That's always a possibility. I've tucked myself away in the back part of the house, so not sure if that'll happen, but wouldn't be surprised. So anyhow, Leela is 11 years old. She just finished up in the 5th grade and will be starting middle school this fall. And to my surprise, my husband's surprise, as the year ended up, she just started thriving halfway through elementary school and ended the year participating in all kinds of organizations, Girl Scouts, girls track. She did 5th grade girls basketball. And for 2 years, she participated in the school's speech tournament, which required her to memorize lines and audibly say them in front of a judge. Many of those judges she did not know. Never in my wildest dreams did I imagine that my child with selective mutism back in kindergarten, who literally looked like a deer in headlights, would end up having such a successful completion of her elementary career. And when she was first diagnosed, her inability to communicate at school, it was really confusing to myself and my husband, particularly because she had such a boisterous personality at home. And we were very fortunate. Her diagnosis came along in kindergarten, thanks to a school psychologist that brought it to our attention. Initially, my husband and I didn't think too much of it, especially because our older 2 children, she's our youngest, our older 2 were also a little on the quiet side and a little shy. So when Leela started exhibiting some of those same personality traits, we just thought it was, shyness, which probably a lot of you guys have heard at some point along the way. And then it wasn't until the school psychologist pulled me aside that fall and Leela's kindergarten teacher and made mention of the diagnosis of selective mutism. So certainly as the night goes on and as I do my presentation, like I said, I'm going to circle back and kind of share with you some of the anecdotal experiences that we had with my daughter, because I do feel for you as parents, it's really important, almost just as important to hear that side of it as it is to hear some of the medical pieces of it as well. So let me just hit on some of the objectives that we do want to accomplish in today's dialogue. So obviously the focus will be be on medication and the medication treatment that's involved, but I am going to take a step back and just kind of explain, a little bit about the basics of defining selective mutism, some of the traditional treatment courses that a lot of kids are starting on. Many of your children may have already gone through some of these. And then we'll definitely talk about some of those risk factors that a lot of kids have that could potentially increase their risk or need for incorporating medication into their treatment plan. And then, of course, we're going to learn about some of the medications that are available. We'll discuss the safety and efficacy, why they're used and why they're safe. And then, of course, I'd like you to understand by the end of the presentation some of the clinical outcomes that can vary quite a bit when medication is incorporated into the treatment plan. So let's start with the basics. What is selective mutism? So the official DSM-5 criteria, as you see here, selective mutism is a childhood disorder typified by an inability to speak in certain circumstances. Specifically, it is a consistent failure to speak in certain social situations where there is a natural expectation of speaking. So this is sort of the criteria that, a lot of the therapists, psychiatrists, psychologists are looking for when they're doing a clinical assessment in trying to understand if a child has selective mutism. The thing that's really tricky about selective mutism is it can look very different in each child that has a diagnosis of selective mutism. Some kids feel like they're comfortable talking to adults in a school setting, but they can't talk to peers. Some kids are the opposite. They can talk to peers, but not adults. And some kids, it's just very circumstantial, depending on which environment they're in. For my daughter, for example, she was completely mute. She could not speak to friends or adults in school. It was the school setting that was a trigger for her. I think a lot of times our therapists refer to it as it being contaminated. I always found that sounds so awful, but that's truly what it was. And even when my husband or I were speaking to her inside the school building, she really was only able to whisper or talk in our ears so that it wasn't audible to anybody else. And then, of course, we worked through that. So oftentimes, because it can look so different in every child, it's a difficult diagnosis to come to, and it can often delay the diagnostic process, in getting children officially diagnosed with selective mutism and then getting proper therapy started. So a question that I get asked often about this, or as it relates to this, is who can diagnose my child with selective mutism? And typically, when your child does start to show a lot of these symptoms, and obviously you as parents will start to be aware of what information is out there, and if they're meeting the criteria, your first step will be to discuss it with a therapist or a counselor or a psychologist or even someone at school. And like I said, in our case, it was our school psychologist that brought it to our attention. So any one of these clinicians can diagnose selective mutism. But I will say that it's becoming more and more mainstream. Part of my involvement with the Selective Mutism Association is I want to bring awareness within my community of colleagues, within primary care doctors, family doctors, pediatricians, because oftentimes we are the gateway and the first person or provider that a lot of these families see. So I would encourage you, if you do recognize symptoms that are concerning, don't be afraid to talk to your pediatrician or your family practice doctor or your primary care physician. There may be some doctors that are still not fully comfortable with helping you make the official diagnosis, but all the primary care doctors and certainly pediatricians will have resources. They can help guide you to the right people to have that diagnosis made. So definitely don't shy away from that. So initial treatment, the common modalities that are often started in children once they are diagnosed with selective mutism looks kind of like this algorithm. A lot of times, you'll start with some kind of therapy or counseling. And the biggest thing to keep in mind as you start some of these basic therapies for your child, and probably many of you have already encountered, is that you really want to make sure you're working with a therapist or a psychologist that understands selective mutism, because so much of the exposure therapy is very unique and specific to kids with selective mutism versus just kids with generalized anxiety. And so if you don't have a therapist that fully understands that, you may not have as much success with those therapeutic options. The other piece of it is, of course, family counseling. And a lot of times the therapists and psychiatrists or psychologists will really help train parents in what they can do. I know for my husband and I, it was a very steep learning curve, because as a parent, you want to step in and rescue your child in those social situations where they get really uncomfortable. And it's hard to train our brain to do the exact opposite. And so it's really important. I know I learned a lot of techniques on how to support my child, but not enable her, so that you're not reinforcing that negative behavior, not to speak, but rather the positive therapy and positive reinforcement. So between the exposure therapy and family counseling, again, it's really important to get connected with a therapy group that understands selective mutism, so that they can best guide you with the right type of therapy and counseling. The other piece of it that is often really challenging, but very important, is that school support. Most kids, or many kids, I should say, that's where their triggers are. You know, it's in that school setting, when they're in a different setting or different environment from being in the comfort of their home. And so having that school support is going to be really critical to their gains and success that they have as they overcome a lot of the obstacles. There are plans in place that can help provide these kids with special resources. An IEP, or an individualized educational plan, or a 504 plan, are some of the types of resources available in our public schools in most states. It can be a little bit trickier if it's a private school, but ultimately school support is very important. And I know this is an area where a lot of parents will hit a little bit of a roadblock or find some difficulties. I know that, Jonathan referred to the Selective Mutism Association YouTube channel. There are some excellent webinars on that channel, as well as some resources on the Selective Mutism website that can help guide parents on how to approach the school team, because that is going to be a really critical part. We were very fortunate with my daughter's treatment that we had a very supportive school team, everyone from the school psychologist, the teachers, the principal, the school social worker. They were all very involved in Leela's treatment plan. And then lastly, as you sort of stepwise approach the therapeutic modalities here, the last but not least is the most important. And you all have probably heard, your therapist say at some point that therapy doesn't end in the office, in the clinician's office. It has to continue at home, and it has to continue into the community. So that daily exposure really has to happen almost on a regular basis. Every day there should be some daily exposure, some challenge that you're posing to your child, whether that's ordering through a drive-through, making a phone call to a family member, going to the grocery store or going to Target and asking your child to talk to one of the someone who works there and asking where something is, what's the cost of something. These are really small but very difficult challenges for a lot of our kids with selective mutism. And it's so important for those to happen on a daily basis, for the kids to get that practice of exposure and brave talking. So this is just kind of an outline, and again, a review for most of you of probably what you are somewhere along this path already. But the next question is, well, what if we've done that and it still isn't enough? Then what? So I wanted to talk about, how does therapy work? And then what are some of these risk factors that we look at? So therapy, of course, is going to be most effective if it's started as early as possible. And so once a child is diagnosed with selective mutism, it's going to be really important to get that therapy started right away, especially if they're younger. If they're older, then of course, getting that started right away is going to be even more critical. Most therapists will recommend to work with the child and continue therapy for at least 8 to 12 weeks. And when it's done correctly and consistently, a lot of progress can be seen in that time frame, but it's still not overnight. I know that as parents, we just want to see it working. And there's always ebbs and flows. Child may have success and gains 1 week and then setbacks the next week. So that's always expected too, but you really do want to give it that full 8 to 12 weeks. After that time frame is when most therapists will say, okay, we've made some gains, but we're definitely hitting some roadblocks now. We're not able to continue to see the success that we were seeing early on. So what do we do next? And so that's when they may recommend adding on medication as an adjunct. And so I want to talk to you about some of the risk factors that we see in kids who have anxiety and who have selective mutism that often end up then also having to add on a medication to help support that treatment plan. So first is going to be their age. So we know that for older kids, they become very good at learning how to navigate school, how to navigate friends and family without having to talk. And they do just fine. They get by just fine. They're successful academically. And so unfortunately, what happens is as they start to continue these learned behaviors, it is a little bit more challenging to undo some of these learned behaviors. And so in our older kids, sometimes medication is added on as an adjunct to help them overcome some of these learned behaviors that they've been doing for such a long time. Family history is another important factor that we consider, and often we see in children who end up needing medication in that there may be a family history of a parent that had anxiety or depression or even selective mutism. And the other piece of the family history that's really valuable is if that is the case, that there is a family history of one of those diagnoses, and there was a family member that was treated with medication, that's a really important piece of information to share with your clinician or with the provider that's going to be prescribing the medication. More and more, we're finding that there's a really strong genetic component on how we metabolize medication in relation to how our family members metabolize medication. So if we know that there was a family member that has a history of any one of these diagnoses and was on a particular medicine and was successful with that medication, then that could be very helpful information. And it could also be a very helpful medication for that child as well. So comorbidities, comorbid condition, what does that mean? So comorbidity is when there is another associated condition that's very commonly found with selective mutism. And there are a handful of conditions like this that we do see in kids that are diagnosed with selective mutism. The two most common that come to mind are just an underlying generalized anxiety disorder. And then we also do see ADHD quite often in many of these kids with selective mutism. Sometimes there will also be some level of depression. And if not early on, that is something that can develop even later as they get older. So we do really look for any of those types of comorbid conditions. When there is a comorbid condition, in addition to the selective mutism, oftentimes those symptoms will definitely be more severe and unfortunately may not be able to treat just with therapy alone. So medication may be used as an adjunct again in that treatment plan. And then lastly, like we kind of touched on, let's say you've connected with an excellent therapy group, you've got school on board, you're doing the community exposure therapy, but you're just hitting a little bit of a roadblock. Unsuccessful behavioral therapy, especially if it's been done correctly and consistently, and for at least a couple of months, 2 to 3 months, and you're really just not making the progress that you want to see, then oftentimes medication can be added. That's sort of where we were at with my daughter. She, like I said, had full support with the school. We were so fortunate. We actually attended our first Selective Mutism Association conference as parents back in 2018, and connected with some amazing therapists and found resources there. So she was probably receiving pretty intensive therapy, both in school and outside of school, for just a little over a year. And we did make some tremendous gains and success, even in that 9 to 12 month time frame. But we were definitely recognizing that there were some things that she just couldn't, some obstacles that she just couldn't surmount. And Leela we did have a comorbid condition for her as well. She also had generalized anxiety disorder, or has generalized anxiety disorder. So, with that, there were certain physical inhibitions that she couldn't overcome, even when she was practicing to do brave talking. And so she struggled in some of the classes, like the specials classes like PE or music. Physically, she just couldn't participate. She would stand on the side, couldn't participate. Even fun, activities like recess, that unstructured, overwhelming activity was too much for her. She would stand on the blacktop and was unable to participate. So we knew that despite working with, some amazing therapists and with school, after about a year, it wasn't going to be enough. So we made the decision, and it was a difficult decision, even knowing what I know about the medications. And at the time, I didn't know as much. I've come to learn a lot more over the last several years. But at that time, she was only 7. And so it was a really difficult decision that my husband and I had to make. But with the guidance of her therapists and her teachers, we decided to move forward with that. So let's talk about, the fear, right? Fear of starting the medication. What drives this fear for a lot of our parents? I would say number one is just misconceptions. There's a lot of misinformation, unfortunately, about medications and how they work and what they do and long-term side effects. And again, I love the fact that we live in a world where we have access to so much good information, so much information in general on the internet and social media, but unfortunately, not all of it is accurate, and so that's part of why I do, these Instagram channels, and I do these webinars, because I want to make sure that we're providing good, accurate information and educating parents so that they can make the best choices for their children. Because unfortunately, there is a lot of misinformation and there's a lot of misconceptions. So I'm hoping that as we go through this webinar tonight, I will definitely be able to help alleviate some of those misunderstandings for you guys as well. The other factor is a societal factor. I think there's still like a little bit of a societal taboo on starting medication or needing to be on any kind of antidepressant or anti-anxiety medications. And we've come a really long way as a society. I think that people are no longer afraid to talk about mental wellness. And there's definitely amongst the pediatric community, much more embracing and even proactively asking these questions so that we can catch them early on. But I can understand culturally and even as a society, there's still a little bit of that kind of worry or fear about what will people think if they know that I'm on medicine or that my child is on medication. And then lastly, I think some of that fear comes just from not having enough of an understanding of how the medications work. Why are they safe? How do we know that? And that lack of understanding can definitely lead to some fear or skepticism about whether or not the medication is the right step for your family. So again, today I want to definitely help fill some of those gaps as you guys learn a little bit about these medications. So let's dive in, right? The crux of the topic today is the medications that we use in treating kids with selective mutism and treating kids with anxiety and even depression. So the most common medication and the one that's really been known to be the safest and most effective in the pediatric and adolescent population are the selective serotonin reuptake inhibitors. Whew, it's like a big mouthful, right? So you will often hear your clinicians, providers refer to these as SSRIs, much easier to say. And again, these have been known to be the most effective and safest. So I'm going to kind of walk you through what exactly do SSRIs do. So serotonin is a chemical that's found in our body. It's produced by our body, and it is what we refer to often as the feel-good hormone. It's the chemical that helps us improve our mood. It helps decrease that inhibition. And oftentimes when you hear about psychiatrists referring to a chemical imbalance, this is what they're talking about, is that in some children and in some adults, the levels of serotonin are not as high as they should be for them to function day to day and feel happy and good about it. And so an SSRI, a selective serotonin reuptake inhibitor, exactly as its name describes, what that does physiologically, without getting into too much of the detail of the biochemistry, is that it basically allows the cells to prevent from reuptaking that back into the cell and leaving more and more of that serotonin in the extracellular level and being used as a neurotransmitter in that area that coats our brain. And so those higher levels then of serotonin that will be available in the bloodstream will overall help improve the mood. It'll help decrease that inhibition. And it really is the best choice from a medication standpoint of treating anxiety and depression in our children and adolescents. So that's, a lot of people feel, again, there's this misconception that, some foreign hormone is going to be introduced into the body, or there's going to be some, outside force or something new that is not natural inside our body that's going to be introduced through medication. And that's not the case. It's just a hormone, a chemical that's already produced. It's a neurotransmitter that we already have. It's just altering how much of it is circulating in our bloodstream. Another misconception that I often get asked about, and it kind of relates back to that fear that a lot of parents have, is, gosh, if I start my child on medicine, I'm signing them off for the rest of their life on medication. And this is the beginning of the end. And that is completely untrue. In fact, most clinicians will start medication with a goal, especially in the younger kids, of being on it for about 6 to 12 months, and then hopefully trying to taper them off of it. Now, there are kids, and certainly older kids, that may end up staying on it a little bit longer, and that's okay too. But the goal or the intention when medication is started is never long-term. It's always to see if we can get them through the worst of it and then eventually try to taper them off of it. And in fact, a lot of the studies, a couple of them I will refer to later on in the talk, have found that in younger children, the reason that the response is even better than it is sometimes in our older kids to medication is that what this medication does by improving their mood and decreasing that inhibition, it allows them to do things and to participate in activities that were very challenging or almost impossible for them to do before, with the level of anxiety that was so high. And so when they're able to do these types of activities and they have a positive association, because again, most of these activities are fun, they want to do them, they just couldn't get themselves to do it, that positive association then sort of imprints in their brain, and their frontal cortex is still developing. So as they continue continue to have more and more of these positive associations, and that imprinting becomes almost commonplace, then over time, their brain just associates that activity as being fun and doesn't need to rely on the medication to provide that extra support. So I will give you, for example, with my daughter, and I'm sure, again, many of you have probably experienced this as well. When they're younger in kindergarten and first grade, they get invited to every single student's birthday party. And my daughter wanted to go and would be excited, and we would practice and all the stuff. And then we'd get there and she would be unable to get out of the car, or we would get to the location and she wouldn't be able to go inside, or she wouldn't be able to wish her friend a happy birthday. And so these were things she really wanted to do. And we'd get back in the car and she'd say to me, and it was so heartbreaking, she'd say, I really want to go. My mind is just preventing me from being able to do it. And there's no rhyme or reason. That's what anxiety is. There's no explanation of why she feels that way. It's just how she felt. It's what her chemical balance was making her do. So when she started the medication, and I'll walk you through sort of what that looked like for us as well. She was able to do these things. The challenges that her anxiety, when it was so high, as it lowered because of the medication, allowing it to decrease her inhibition, she was able to participate in birthday parties. She was able to play during recess. And the more she did that, the more positive that association became. And it was fun. She loved it. She wanted to do more of that. So over time, even when we weaned her off the medication, she didn't need it anymore because her brain had already imprinted that cycle of positive association. And it feels good. And I like this. And it's easy. And I can do it. So oftentimes, that's the goal that we're looking for, whether it's young children, some of our older children, or even our adolescents. And remember, when we talk about our adolescents, that frontal cortex is not fully developed in young adults until about 21 to 25 years of age. Sometimes maybe even a little older. Some of our young adults struggle even still with learning some of those developmental skills. But that frontal cortex continues to develop all the way up until 25 years of age. So it's not too late, even if you have a teenager or a young adult that's really trying to work through some of these struggles, because anything you can do to help decrease that inhibition and allow them to be able to participate in ways that they've always wanted to will help create that positive association. And then they don't need to be on the medication forever. So there is a lot of good that comes out of that. So with Leela, specifically, as I said, we started her on the medication. She was 7 at the time, and she ended up only needing to be on it for about 12 months. So she was on it for almost exactly a year. And, the nice thing was she was old enough to tell us how she was feeling. And she, at one point, I remember towards the tail end, around 10 or 11 months of her being on the medicine, said to me that, I can do my brave talking on my own now. I don't need the medicine to help me anymore. And that's when, we really started having that conversation with her psychiatrist about whether we consider a taper. I was a little nervous, because it was right for her. It was between 2nd and 3rd grade. It was right when COVID hit, and she was going to be going into distant learning. And I was really nervous about taking her off the medicine and tapering her off when we were going to be doing distant learning, which is often very challenging for some of our kids with anxiety. But anyway, she did it successfully, and she was only on it for 12 months, and she was a completely different child after having been on the medication. It is something too that I reinforce, especially with the younger kiddos. I always want to remind them that this is not a magic pill. It's not the medicine that's doing any of the work. You're still doing this work. You're putting in all of the hard work and effort in helping yourself be brave. The medicine is only just supporting you a little bit to be able to do that. And I think that's an important message, especially if kids are started on medicine at a younger age. It's really important for them to understand there's no dependency here. I'm not dependent on this medicine. The medicine is just supporting me for as long as I need that support. So I think that's another important distinction even for parents to understand, it's not a magic pill. And we'll get into that because I'm going to show you some data on what we've found in some of the studies that have been done when you compare treatment of therapy versus medicine and together. But it's not a magic pill, and I never want kids to feel like they're dependent. And parents should understand that this is not going to create a dependency for them either. It's only going to give them that support for as long as they need it. So let's talk about a little bit more about these SSRIs. There are two most commonly used SSRIs in this family that you're going to see most often, or even have suggestions made. One of them is Zoloft. That's the brand name. The generic name is sertraline. And then the other one is called Prozac or fluoxetine. The reason that these are used most commonly is, again, they are the safest, most effective, and they have actually been studied in clinical trials and found to have a very good and appropriate safety profile in this age group. One of my colleagues, who is a pediatric psychiatrist, Dr. Jim McKenzie, is wonderful. He really helped guide a lot of pediatricians with that extra continuing medical education so that we could provide these types of services to our patients. He referred to these medications, and I'll quote, as benign medications. I know as a parent, it's kind of like, eye-opening, like, are you kidding me? But as a psychiatrist, they really feel, again, when these medications are used safely and correctly, they are very, very effective. And he even said, to a group of our pediatric colleagues, he said, you guys, and as pediatricians, I want to qualify that this is not training that we necessarily get in medical school about specifically how to treat mental health or mental illnesses. So it is definitely something new, and we have a lot of support from our psychiatry colleagues in helping us do that. So a lot of pediatricians are reluctant. Some are still learning. I feel, again, very thankful that I've had both personal experience to be able to incorporate into what I do professionally. But he did say to us, he said, you will not, if you use them, the way we teach you and safely, correctly, you will not do any harm to your patients. And that's the thing I think most pediatricians are often afraid of. And parents, of course, are worried about. So these are, again, in a psychiatrist's eyes, benign medications that can do no harm. So that's reassuring. I'm going to show these two slides. I'll put them up here more just so you have the information. It does get into a little bit of the nitty gritty, probably more beneficial for clinicians and other pediatricians to see, but certainly as a parent, it would be helpful for you to know so that if you're working alongside with your pediatrician, you can certainly help them and let them know sort of what is the common practice in prescribing. So here I have the one for Zoloft or sertraline. And you'll see that, a normal dose in an older child or an adult for sertraline, when you're treating anxiety or selective mutism, the average starting dose is about 25 milligrams. However, what we found is in our younger kids, you can usually even start at half of that traditional dose. So 12.5 milligrams a day can be very appropriate. And this is a little difficult to kind of understand, especially as a pediatrician, because so much of what we do when we're prescribing medications, we are dosing them typically on the size of the child, the weight of the child, and the age of the child. So some of that comes into play here, but it is important to remember that different kids metabolize these medications differently. So with medications like SSRIs, with medications that fall into the stimulant category for things like ADHD, those don't follow the traditional model of using weight or size even on dosing. Those are going to depend more on how quickly that child metabolizes that medication. So oftentimes you can have a younger child on a higher dose because they have a higher metabolism than that same medication on an older child, where it could be a little bit lower because they metabolize it slowly. And they may have other tools that they've already incorporated into their day-to-day functioning that don't require them to have or need as high of a dosing. So it is a little different than most pediatric medications, but always can be started in the younger age group at a lower dose and then titrated very, very slowly. So we start low and go slow. That's the motto. And if you follow that motto, and most our clinicians do, psychiatrists also follow that same mantra with these particular medications, that's when you won't do any harm and you'll be able to maximize the positive benefits of the medication without really getting into any of the side effects. The other thing, and I'll put up the slide here for Prozac as well. Prozac is probably, fluoxetine is probably used more when there are some of those comorbidities that we talked about earlier. So typically, when kids have some more depressive symptoms, you may see, the clinician recommending Prozac over Zoloft. But both are in the same family of SSRIs and can be equally effective for both depression and anxiety. The other nice thing about these formulations is that they do come in kid-friendly options. So there are liquid formulations, there are capsules that can be opened, and those can be sprinkled onto yogurt or applesauce pudding, lots of different ways to take them. My daughter, I'll go back to this, was on the Zoloft. She was started at that 12.5 milligram dose. And actually that's all she needed. Her anxiety was high enough that she needed something, but because she was still getting such great therapy and we were really working with her therapist both inside of school as well as in the community, she never went above the 12.5 dosing. She stayed on that same dose for the entire 12 months that she was on therapy. So again, you start low and you go slow. The titration, I don't recommend really going up until at least about 4 to 6 weeks of trying at that dose, and then potentially going up to the next level if indicated. These medications, again, we sort of, I'm going to come back to saying they're not a magic pill. They still require work with the therapist. Continuing therapy is very important even when a child is started on medicine, but they can take about 6 to 8 weeks to really show true effectiveness. So again, it's just, important to be patient. And that's why the pediatrician or your psychiatrist that's prescribing it will check in with you pretty regularly, at least in the beginning, because we do want to make sure there are no side effects, but that, we've given it about 6 to 8 weeks of time to work effectively. Okay, so let's talk about side effects. This often can be the scariest part for parents about why to not start medications. So the first thing that I want to distinguish here is the difference between most common side effect versus most concerning, also usually least likely. So it's very, very important to remember that while there is and can be a most concerning side effect, that's usually the least likely side effect. But of course, does have to be discussed and talked about because there can be some patients that do react that way. So the most common side effects that we're going to see when we first start these medications, and usually these side effects are what I describe to patients as transient, meaning that they're not going to last for the entire duration of the treatment. Most kids will experience these side effects in the first couple of weeks. And then as their body sort of adjusts to the new levels of serotonin, and the new medication, a lot of these will sort of wear off and they will hopefully start gaining so many positive results or outcomes from the medicine that these will be even less and less significant. Our stomach is lined with serotonin receptors. So when we talk about, how those serotonin levels are going to increase, they are going to help in the brain, but they also are going to trigger our stomach. So some kids may have some GI sensitivities. It may potentially affect their appetite, not enough to have any dramatic impact on their overall growth, but more of just kind of that uncomfortable feeling in their tummy, a little bit of nausea. My dear colleague, Dr. McKenzie, told us to tell our patients when they first start these medications, they may feel what he refers to as Taco Bell tummy. Kind of when you eat those fast food items that you love and then afterwards feel regret that, oh, maybe I shouldn't have eaten them. So that's how I describe it to especially a lot of my younger patients, that you may feel a little Taco Bell tummy, but that will get better. So those are expected and common side effects that usually do subside and don't cause enough concern where the medications need to be stopped or changed. Some kids may experience a little bit of a headache, again, as those serotonin levels start to increase. That's not uncommon. The other more common side effect, and I describe to parents and patients, is that you're going to feel a little bit activated. So not hyper, but a little more activated. You may be more likely to talk more than you normally would. You may be more likely to talk to people that you normally wouldn't have spoken to. You may wave to an old neighbor as you're walking by that you never have said hello to before. And these are normal. This is what we want, especially in our kids with SM. We want them to be able to be verbal. We want to decrease that inhibition. But a lot of times it can be very eye-opening, or can cause a real stark reaction for parents because they're not used to seeing their kids react that way. Again, this is a very transient reaction, usually levels off, and most kids don't have any discomfort from it, but it is a reaction that we commonly see. Due to that level of activation and maybe a little agitation, some kids may have some sleep disturbances early on when they first start the medication, but that too will subside. So let's talk about the most concerning side effect, this black box warning. So back in 2004, the FDA required all SSRIs to have this black box warning indication put on there, which is basically that there is a 1 to 2% increase in risk of suicidal ideations in certain patients taking SSRIs. So this is really important to understand. That first off, it's just an increase in suicidal ideations, or the thoughts of hurting someone or hurting oneself, but no actual completed suicides ever resulted from this medication. And secondly, that certain patient population base that they're referring to that often do use SSRIs may be more kids who do have more severe depression, adults that may have more severe depression and can have this type of response. Most of my kids, I should say, actually, I haven't had any kids who I've used SSRIs on for anxiety or selective mutism that have responded in this way. But it's really important for caretakers to be aware of it. It's equally important for patients to be aware of it. I will tell even my youngest patients, if you start having any silly thoughts or any thoughts that scare you, let us know. And I will specifically ask if they're having any thoughts of hurting themselves or hurting others when I do their follow-ups. It's really important that I ask them direct questions that they can help answer, so that we can make sure they're not having any of these side effects. So this is, again, a side effect. Now, I will also mention real quickly, in the study, when they found that these side effects were happening, they also found that the group that was on the placebo medicine, meaning the sugar pills or not taking medicines, also did show, some of that group did show some increase in suicidal ideation. So that's why, it's a very small subset, and generally in our pediatric patient population, thankfully, we don't see much of it, but it is something that parents do need to be aware of. Typically, if they're going to have this side effect, we are going to see it usually in that first 7 to 9 days of starting the medications. Within that first week or two is when you're going to be at highest risk of seeing these types of thoughts. So again, that early follow through is really important. And you're also going to see it more if there is a significantly higher dose that was started than what should have been. So if they were started on too high of a dose right off the bat, that could also increase the risk of these types of side effects occurring. So that's why, again, start low, go slow is always a good motto. For most kids, even with the most common side effects, and certainly if it was a more concerning one, we might consider changing the medication. But with the most common side effects in place, the risk of having these suicidal ideations usually is dramatically outweighed by all of the benefits that they start to see in decreasing their depression, decreasing their anxiety. So it does make it worthwhile. Really quickly, I just want to tell you the names of, there's been several different studies that have been done, but the two most common ones that you are welcome to refer to as well. The first one, it's called CAMS, the Child and Adolescent Anxiety Multimodal Study. And that one was the most recent study in 2010, was a randomized controlled trial, did take place over a course of 6 years with about 500 children, age range of 7 to 17. The TAD study, Treatment of Adolescents with Depression study, was a little bit of an older study. It was in 2007, also a randomized controlled trial. What that means is it was done in a scientific method, followed the rules of what studies should do to get accurate information and draw good conclusions. It was a shorter study, just 9 months, with a smaller subset of participants, but older, a little bit in the older age group. And both of these studies were very important in really helping determine the safety and efficacy of using these medications. And just as a caveat, I'll mention that doing clinical trials in children is really difficult. You have to go through lots of different types of approvals to even be able to set up a study that can safely be done in children. And in fact, many medications that we use day to day in pediatrics are not even officially FDA approved, but they're used more based on our own experience, on anecdotal experience, on information and education that's passed down from pediatricians previous to us. So keeping that in mind, having these studies really does help support the safety, and it helps support the safety and efficacy, but also helps support us in feeling, safe to use these particular medications, knowing that they were tested. And then, really just to kind of come back to the data, this is what we found. These studies showed that in the groups that just received therapy alone, there was a substantial improvement in their symptoms, somewhere even in the range of 60 to 70% improvement just with therapy. So that again really points out how important therapy is in all of this. Whether or not medication is added in, for some of those kids at some point may be indicated or necessary, but therapy alone can be so beneficial. In those kids that received medicine alone, we saw much lower improvement in symptoms. The range was more in the 40 to 50%. Again, coming back to, what I was saying earlier is there's no such thing as a magic pill. I wish I could just say, take this pill and everything will be better. But unfortunately, that's not the case. And it's clearly evident here when you see that for those kids who share some of those risk factors that we talked about earlier, when you do the combination of therapy and medication together, the range actually was all the way from 80 to 95% improvement in symptoms, the average being 81% when combining therapy and medication. So that's why it's so important that if a therapist recommends that your child may need medication, while that piece of it is going to add that adjunctive treatment and support, you don't want to discontinue the therapy. That therapy is going to, the treatment is going to be much more successful if the therapy is continued along with adding on that medication. So kind of coming back full circle to Leela, we were, again, so fortunate to have successful intervention in a timely way with a very supportive team of therapists, a very supportive psychiatrist, and a very, very supportive school team from, everybody from her teacher, principal, social worker, and school psychologist. So and school speech therapist actually was involved heavily with that. So we were just very fortunate to have that. And, just to give you an idea, again, Leela is thriving. She ended her elementary school career so successfully. She's excited as she prepares to start middle school in the fall. This summer, she actually wanted to do an improv class where she had to come out of her shell, use her brave voice in a very audible way, participated in this improv class, which I was very proud of her for doing. She successfully attended her very first sleepover birthday party with no tears, no tummy aches, and did a great job and had so much fun doing that. And then she actually just came and told me earlier this week that she wants to try out for the middle school basketball team and the middle school golf team. So, we've really come a very long way with Leela's progress. She is no longer getting regular therapy. We still touch base with some of her therapists. We've learned as parents what we can do for her at home and in the community. And she is obviously no longer on medication. Like I said earlier, she was only on it for 12 months. So, success can be had. And sometimes while it's scary, adding on that medication can be very helpful for those kids who need it. So I apologize, I ran a little longer than I was expecting to, but I hope people can stay on. I'm happy to address questions that may have come up during our talk. I will put up this slide again just to share my information about my practice. And please do take a look at my Instagram channel. And definitely, if you don't already follow the Selective Mutism Association, there is an Instagram channel that we have that shares lots of good information and a website that has amazing resources, and then our YouTube channel as well. So thank you guys for joining and listening. I will turn it back over to Jonathan. If you can help me navigate some of the questions, I'd be happy to go through those as well.
Want to be mindful of everybody's time, but thanks so much for the presentation. Hopefully we can just get through a few of these questions. I think I can maybe summarize some of them into one or two. But yeah, such a great talk, and appreciate you weaving together both your personal experience and also your clinical experience and clinical judgment. I think that's a great thing to see. So a lot of the questions have to do with what should I do if my child doesn't respond to the medication? We're on the medication for 6 months, we're not seeing progress or having too many side effects. What do you typically propose as the next steps in those types of situations?
Yeah, that's a great question. And so I think for a lot of kids, the first thing to look at is which medicine they're on and what their dose is. So if you're at a point where you're on a medicine, but you're not really seeing any side effects, it's possible that you haven't actually reached the therapeutic dose yet. And don't be scared to continue as long as you're titrating and your clinician is helping you with that titration in a slow and safe way. You may find that you do have to go up to a higher dose, especially in an older child, or for example, in a child that might be going through some growth spurts, a dose that was working great for them, all of a sudden doesn't seem like it's effective anymore. With sertraline, the maximum dose, and I had that slide up, can be even up to 200. I'd say most of my adolescents that I have on that, the sweet spot usually is somewhere about 100 to 150 milligrams. So it can definitely be titrated up. That's when getting a psychiatrist involved is going to also be helpful. I know for myself as a pediatrician, I have, sort of a small repertoire of medications that I feel comfortable with. But if we've tried one and it's not effective, a lot of times I will maximize that medication. So for example, if your child's been on the sertraline, maximize the dose that you think is effective or should be, and it isn't, then we can titrate them off of that, and at the same time titrate them on to the fluoxetine and try that. Again, how they metabolize it could be different for each child. So that could be something that's done with the help and guidance of a psychiatrist. The other thing too to keep in mind is still continue with therapy. It's not enough sometimes to just be on the medicine. It's really, you may have to intensify their therapy, make it a little bit more frequent, find other ways to keep that exposure going, whether it's, at home or in the community, and really working with those therapists who understand the nuances of how to work with kids with SM. And so, don't give up, keep trying. 6 months of being on medicine, it could be that you're working up towards the success, but you may just still need to, every time you go up on a new dose, you kind of have to give it that same 2 months, that 6 to 8 weeks of the new dose. Think of it as a whole new medication. So just be patient with that, but keep trying.
What are your kind of thoughts on a decision if you are at a plateau to increase the dose on the current medication, or how do you know when to switch?
Yeah, so I would say definitely increase dose until you maximize a dose where you're not having dramatic side effects. So again, a lot of times when I have a child that's telling me they have absolutely no side effects, but it's not helping, what that usually tells me is we're not really at the therapeutic dose. Sometimes you want to see a little bit of the negative side effect. You want them to say, well, my tummy didn't feel great, but I still feel so much better on the medicine. Then you know that you are starting to maximize those receptors, that we want to really make sure that we're utilizing. So I would say maximize until you reach a point where you're starting to have negative side effects. And if you're getting negative side effects, but still not reaping the positive side effects, then that may not be the right medication. And it might be time to try and switch to a different one.
Great. Thank you. And here's another one that I thought was pretty interesting and also impacted me when I was kind of growing up. When I had selective mutism, was that someone being on meds for 6 to 12 months, then they taper off. What happens if they need to go back on meds a few years later? And how do you think about
That's a
that?
great question. Yeah, that's a great question. And so one of my takeaways from the therapists that we worked with for Leela's treatment, it actually told us that, there's going to be these ebbs and flows. And I'm very well aware that while we had the success and she successfully was able to complete elementary school, coming on to middle school, a whole new challenge, a whole new environment could potentially create setbacks. So I think every parent has to understand that there's going to be times in your child's life, even if they've really mastered so much and gained success, you probably won't regress back to a point where they're in that deer in the headlights again, but there will be what I refer to as kind of ebbs and flows. And that's okay. That's expected. And so I'm fully aware that at some point in time, we may have to readdress medication again, depending on if those symptoms really start to show up and start to really affect her day-to-day functioning. If it starts to create that inhibition enough where she's struggling doing things like just going to school, we may end up revisiting the idea of medication. And that's normal. That's normal for children, adolescents, and adults. Sometimes you do have to kind of you go on it, you help you help get to where you need to be, you can go off of it, but you may need to at some point restart it again.
Makes a lot of sense. Thank you. I guess maybe do this one last question. Again, I want to be mindful of time. We got one question about this, and I've also heard this from many parents about, I think you kind of touched on this earlier, about like those genetic tests to tell you what medications might be helpful based on how well you metabolize it. Can you give like a brief overview of those? Do you recommend them? Do you think that they're useful?
Yeah. I'll be totally honest. I don't find them super helpful yet. I think that we will reach a point in time when they are a little bit more effective. But right now, and I've done them on a handful of patients, by patient request, the information that I got back wasn't very helpful. It's still very difficult to understand what the results truly mean. And especially when you've got a child that's doing well on a medicine, but then you get a result that says that they shouldn't be doing well on that medicine. Like, what are you going to do with that then? Do you follow the results or do you follow the clinical picture? I've always in my practice followed the clinical picture with anything, even when parents call me and their child has a fever and they say, well, he's got a fever of 104, but he's running around like a maniac. Well, he's probably okay. You want to look at the clinical picture, look at the child, use that family history, so maybe I'm a little old school, I'm not big on doing testing, and especially because a lot of these tests are still not approved by insurance companies. So they end up being a real big financial burden for families. And some families, when they're desperate, will feel like, let's just try it. I'll pay, the $2,000 because I want to know. I suppose that there may be circumstances when they could really be helpful if you're really stuck or you've gone through so many different medications and you're really wanting to just see, is there one other thing we can look at to just decide what to try next? I'm not saying that they don't add value. They do. They definitely add value. I just don't know how much of that is valuable in pediatrics, because we're already pretty limited in which medications we use. So yes, they can be helpful. I'm hopeful that they will become more and more helpful as technology improves. But as of now, I have not had tremendous success on using them in my practice.
Great. Want to thank everyone again for joining us. Thanks, Dr. Rupal, for an awesome presentation. Lots of questions we're going to get to, but a lot of them are very, very nuanced and specific and probably not the best format, but if you need a consultation, potentially you can reach out, find a pediatrician or a psychiatrist in your area who can talk more in depth about this. Just final announcements. I want to thank again the Gordon Marilyn Macklin Foundation that made this webinar possible, and all the other ones you can find on our SMA YouTube channel. A link to this recording will be sent to every registrant. And also go to the SMA website to get info on our annual conference in October. There's going to be another medication talk for individuals with selective mutism. If you have a teen who's above, I'm not sure the exact age, but if you have a teen or a young adult who has selective mutism, we have a track in the conference where they can learn about their own medication use potentially. We have other talks for parents that are really awesome. The conference will be in October. Very much encourage you to register. There'll be plenty of talks like this. Yeah, hope everyone has a great night. Thanks again, Dr. Rupal.
Thank you. Thank you, Jonathan, for your help. I appreciate it. And thank you, everyone, for joining. Hope it was helpful. Have a good night.
Hi, everyone.
Bye.